Good afternoon. Welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stein. I'm a family physician here in Vincennes, Indiana, and Chief Medical Officer of Good Samaritan Physician Network. Joining me today, Adam Thacker, who's our Chief Operating Officer and pharmacist, who will be handling all of our difficult pharmacy questions today. We're going to be giving you our usual COVID update. We have moved this to every few weeks or so, but want to touch on some of the points that have been changing over the course of the past month or so. Total numbers to begin off with, about 3,800 total positives from the beginning of this, but the number that we always go back to, of course, is what those positivity rates are. And positivity rates around 4.5% for all individuals, around 10.6% for unique individuals. The good news is our county is still in the blue. Things are looking good with that. The bad news is we're starting to see some yellow cropping up, specifically in the peripheral counties around us. And then most significantly, what we're seeing in the clinical world is we're seeing more people coming in that are showing signs of COVID, being tested and found to be positive for COVID. And that's a very distinctive change really just over the past couple weeks or so.
Right. As you mentioned, we've spread out these COVID updates, and as we were coming up to this date, there was a little bit of, do we have anything to talk about? And in this week really have started to see some things pick up. As you mentioned, over the course of time, we're still way down from the beginning of this, but in the last couple of weeks, and especially when you look at the data in the last 30 days, have seen an increase in cases. We have 21 active cases right now in the county, and in the last 30 days, 42 total cases, but those 21 have all happened in the last week. So certainly seeing an uptick across the state is seeing an uptick. We're feeling that. Still blue, but our region's starting to be more effective. About a 4% increase in hospitalization in Indiana from a state perspective, and so we made the list of those states that are seeing that increase in hospitalization. So it's not just we're seeing positive cases, but we are seeing individuals that are having an illness that leads to a hospitalization.
And many people are asking, why is this happening? Why are we seeing that increase? Normally this time of year, we wouldn't see a lot of viral illness. But certainly one of the consequences, which we spoke about all last year, was timing relating to holidays. And of course, as things have opened back up, as people have started traveling more, certainly summer vacations, 4th of July, Memorial Day, all of the events that have really occurred over the course of the past month or two have increased circulation of people out in the population, have increased exposures, and many of the clinical cases that I've seen in the past week or so have been, I went to a concert, I went on vacation, I came back from this travel experience, and they came up positive within a few days.
Yeah, and let's acknowledge that as capacity limits and masking mandates, so capacity limits have been removed, masking mandates have been lessened, really removed outside of kind of healthcare settings and some food industry, some employers that have continued with that. We expect to see an increase, and not just in COVID, of other viral transmissions that masks help to reduce just across the board. So seeing that uptick is not necessarily something that is, an immediate cause for, hey, shut things down and back to mask. You're going to see some of that ebb and flow. And, take this week, for example, Monday was the All-Star game for Major League Baseball Home Run Derby, and then the game was last night, and you had a full stadium of, 30,000+ folks attending that, and that's great to see it from self-proclaimed sports guy watching all that. It's great to see, but at the same time we have to understand the risk reward of those things, and it kind of comes back to some of those basic parameters that we talked about with hand hygiene. If you feel ill in any way, not going to events and keeping distance and staying away. And if you're in that population that are at higher risk for a poor outcome, have any type of immune system illness or pulmonary illness that are going to be affected to a higher degree, take extra precautions. And then on top of that, I've had numerous individuals mention allergies and the seasonality of that, and mold, and just this time of year seeing that maybe worse than ever, it seems like, which mask somewhat of the COVID symptoms, as you and I talked about. So it's easy to say it's allergies and then go about your business. but do we know it is?
Yeah, absolutely. And that of the patients that I've seen over the course of the last week, every one of them except for one came in with that exact scenario. They came in for a completely separate reason and said, "Hey, by the way, I'm getting my usual sinus infection this time of year." Well, that sinus infection came with muscle aches, body aches, fevers, chills, not typical of that. Or, as you said, of course, with allergy season starting in the spring and continuing until we hit ragweed season in the fall, it's easy to play those off and say, "Oh, I think it's just my usual allergy symptoms." So we want people to be very conscious of what their typical version of that is and not overlook what we've talked about as the common symptoms associated with this. Remember that although this is a cold type virus, it is a systemic illness. And so the systemic nature of it being fevers, chills, feeling badly, although allergies make most of us feel badly, they don't make us feel terribly sick. We generally don't have fever associated with those, muscle aches, joint aches, extreme fatigue. So being cognizant and being watchful for those types of symptoms, and that is definitely beyond what your normal symptom profile would be, and getting in to see your healthcare provider and just being conscious of that, and then exposure to family members. One thing that this sort of takes us back to that has cropped up again is, what do we do about exposures? What do we do about masking? What do we do about quarantining? And one of the big pushes that we were kind of going through over the course of the last several months was lots of reasons to get vaccine, but one of the big pushes for vaccine was also if you happen to have exposure, as we're seeing more cases come up, you don't have to quarantine, which is nice. You need to be conscious of your own symptoms, obviously, and then pull yourself back out into isolation. But if you have somebody that you've been exposed to and you've been vaccinated, then you don't have to do that.
Right. And we've continued to push since December of last year that our vaccination rates decrease infection rates, and that's really our path forward from a moving out of the pandemic standpoint, and that's continued to hold true. You can look at any map across the nation, and high vaccination rates lead to lower infection rates from a COVID standpoint. And the same now holds true with the Delta variant, which has become the predominant variant that we're seeing. 60%, 60% of cases are that variant. It, as with some of the other variants in the evolution, it's high transmissibility, can cause acute illness, hospitalization, but we're seeing vaccines that are very effective. Pfizer has put out actual data saying 88% effective in preventing illness and 97% effective in keeping you out of the hospital, which are very similar numbers to all of the other strains that we have seen. So we'll continue to make that push. And in the next couple of months, maybe even in the next few weeks, we expect some big changes from a vaccine standpoint. We expect the vaccines to be granted full FDA approval, so not under that emergency use. And we've been notified, and anyone that is watching from an employer standpoint has probably been notified as well, that OSHA, the Occupational Safety Health organization that looks at workplace safety, has put out standards, emergency temporary standards for COVID, and they are pushing towards vaccination of employees. You have different basically workplace requirements for vaccinated versus unvaccinated as far as barriers, plexiglass, masking. A return of screening in the hospitals is going to be something that we're looking at. All of these measures are federally mandated by OSHA. This is not a Good Samaritan thinks we should do this. They're federally mandated that by the end of August, we will probably be screening again in an active screening way, where when you come in, you're asked questions. Won't be actively taking temperatures, but we will be asking as far as any symptoms of illness and any known exposures.
And certainly as we move into the fall and then into the winter months, when we anticipate a normal rise in viral illness, that's going to become more important to have that stuff in place.
Right.
Adam brought up the issue of the Delta variant. We get lots of questions with regards to that. Is this a new virus? Is this something different? Every year the flu virus changes. Every year cold viruses change. This is nothing different than any of the other viral illnesses that we see. The Delta variant has just been identified as now the predominant version of the coronavirus in the United States. Missouri was something like 97 or 98% Delta variant. We're, of course, seeing that spread around the Midwest as well. And although the transmissibility of it is really, really high, the good news is we're not seeing that it is as bad in terms of hospitalizations or severe illness. And then the numbers that Adam was quoting are very important to realize too, in that the vaccine is still very effective against the Delta variant, and more importantly, effective in keeping you out of the hospital. One of the big studies that was done just about a month and a half ago through Cleveland Clinic showed that of all the hospitalizations throughout the Cleveland Clinic system, which is a huge system, obviously, 99.7% of those that were hospitalized were unvaccinated. That means if you had the vaccine, your likelihood of having to be hospitalized because of more severe illness was extremely low. So yes, we want people to continue to look at getting vaccinated, get that vaccine set completed if you haven't, and then look at family members, including children, to make sure that if they have the option to get vaccinated, that they do. Now, vaccine clinics changed a few months ago here in terms of what's available, but it's still very easy to get in and get your vaccine now.
Right. Knox County Health Department is still operating a COVID vaccine on Monday, Wednesday, Friday. The access point is the same, ourshot.in.gov. You can go on there, put in zip code, and you will see Knox County Health Department. You will also see the Walgreens, Walmart options. And then if you live in a different county, work in Vincennes, you can look by zip code and see where the other options are. I took a quick glance at it just in kind of preparation for our discussion today, and there is open access every day for those Monday, Wednesday, Fridays moving forward. The common question then becomes which vaccine. They do have the Pfizer vaccine. They also have Moderna, limited supply of J&J, so they actually have all three. So just understand when you're scheduling your vaccine if you need to talk to them about which one would be best for you. Obviously that 12 to 16 population, 12 to 18 population is only approved for Pfizer, so you have to make sure to schedule with that. But they have all three on site, so that's not really something that is of concern. So access is not an issue. Cost, this still remains a federally funded program. There is no cost to getting vaccinated. And we continue to put in the plug of, if you look at vaccination versus recovering from infection to have natural antibodies, vaccination is the safer route in going through that, certainly as the data has shown. It's very easy to get caught up in what's this side effect, that side effect. The Johnson & Johnson vaccine has had the spotlight on it a number of months ago for clotting concern with very few women, very rare, and now more recently in men under the age of 50 that are, or over the age of 50, related to Guillain-Barré, which has been attached to every vaccine we ever talk about. But when you look at the actual data, 100 cases, 13 million doses, 320 million doses across the three vaccines, 100 cases. It hasn't been reported in any of the other vaccines. That in our world is what we would say clinically insignificant. I mean, 100 cases, there are 100, you could pick out of 320 million instances, you can find 100 of anything.
Yeah. And what Adam's talking about, this Guillain-Barré, is something that we have seen with any type of vaccine throughout the ages. And we don't fully understand the process. We think that it's autoimmune. It's after some type of insult to the body. But some cases of Guillain-Barré happen after normal viral illnesses as well. And so the difficult thing is to separate those out. But as Adam's talking about, if anything, if we look statistically across all the vaccines that have been given, this is much lower than many of the other vaccines that we've commonly given over the course of the past 50 years. So just realize that the vaccines are very safe. As Adam was talking about, to move to full authorization out of the emergency use authorization really speaks to the fact that this is very safe. And the massive number of vaccines that have been given also helps tremendously with not just the efficacy data, but to say that this has been proven safe in a very, very large population, including breastfeeding mothers, including pregnancy, including all of these other circumstances that they weren't really sure on initially. And one of the interesting things that has come up that frequently we get asked is, what about boosters? What are we going to know about
Right.
boosters? Adam had mentioned the issue of natural immunity versus vaccine-induced immunity. And what they've found interestingly, which is a little bit surprising, is those that have been vaccinated seem to have better persisting immunity. And we don't fully understand why that is. But as these studies continue to get monitored and they continue to follow these long term, we'll know more when we get to the fall as to whether there will be any boosters that will be required or not. As of right now, there are no recommendations to that. We're encouraging everybody to go out, and if they haven't been vaccinated, get their first vaccine, and realize that it's for your own personal health, it's for the health of your family, it's for the health of your community, and for normalcy. We have all been super excited about some degree of return to normalcy and activities and sports and school and everything else. Our schools are meeting and discussing what that's going to look like. The majority of schools have already issued letters describing kind of what those circumstances will look like going into the fall. I know the school that my children go to has issued a letter that stating masking will not be required. I think most of the schools are coming out with very similar statements that masking certainly can be optional, and then they're encouraging students to get vaccinated as well.
Right, and I really feel like that's the direction that we're going from a county and seeing that statewide and even nationwide from a school standpoint, that masking optional, and that puts more of the emphasis back on, yes, masking is optional, but coming to school sick, not optional.
Right.
If you have a health condition that you know puts you at higher risk, masking should not be optional. Protect yourself. Masks work. They absolutely provide a level of protection, and so somebody wearing a mask, not wearing a mask, that is a choice to a point, but also understanding that you affect the others around you. And the other really key element is that this is a ever-changing environment. So masking optional across the schools, masking optional at businesses, that can change.
Mm-hmm.
And it's all going to be predicated on what we're seeing from a transmission across the communities, and not just here locally, but also communities around us, and the potential risk of transmission, because there are obviously individuals coming in and out of communities every day. And so we have to be aware of that. So nothing that is decided today is set in stone, no different than it was, many months ago. We continue to look at the information. We make changes based off of that information being kind of dissected as what is best for the health and safety of everyone. And that's the paramount decision maker, is what's best for health and safety.
Looking back a year, some of the big issues we were dealing with back then was testing availability, provider availability, access availability, those types of things. And so one thing that we want to get through to everybody is vaccine is readily available. Access to providers is readily available. Testing is readily available. And one of the big things that has really changed over the course of the past few weeks or so is both types of testing are available and rapidly returned. So we have the rapid tests in all of our facilities now that basically get us a result in roughly 15 minutes.
Right.
But also we have the PCR test that's available, and it's returned very quickly as well. A test this morning that was sent off around 9 o'clock, within an hour and a half, we had that test result back also. So testing is readily available. It's highly accurate. We have some people that will ask about the Delta variant testing, and that's not something that really changes what we are doing clinically, whether it's a hospitalized patient or an ambulatory patient. But what happens with Delta variant testing is sampling from a purely population health and epidemiology standpoint. Those tests are being sent off by Dr. Stewart and some of our health experts to determine what the variant is. And we know that has become predominant. That will become less important because the assumption is that that's what we're dealing with. But those samples will be periodically sent off. So we don't specifically test you to find out if you have the Delta variant, but those will be pulled out from time to time to do some testing to determine from a population health standpoint if that's significant or not.
Right. And from a clinical treatment standpoint, it's somewhat irrelevant to us. You treat the patient in front of you based off of their symptoms and illness. We don't have a tablet that cures variant Delta and one that is variant Alpha. So that specificity isn't needed. We're treating the symptoms in front of us. Now, what is coming out from the state, and it was just communicated today, is if you are fully vaccinated, have symptoms, go get tested, test positive, then we will perform off of the rapid test. We will perform the PCR test and that will be sent to the state. Because when we're talking about numbers from Delta variant and vaccine efficacy, that's how those numbers get derived, is that if somebody tests positive, we have to find out what it is if they were vaccinated. The importance of that is that then starts to talk about boosters and reformulation, and you have to have that data to make good decisions. So if you're vaccinated, have symptoms, and get tested, which you should, and test positive with the antigen test, which is the rapid test, then you will be asked that we'll collect another specimen for the molecular test, which will get sent off to the state to test for Delta. Here at Good Samaritan, we will not be able to tell you that. We don't have the equipment that tests at that genetic level.
The other big thing that's important to realize that Adam touched on there was getting tested. Please come in, get tested, determine if that's the cause for a variety of reasons, but not the least of which is the treatment is also readily available. Going back to the very end of 20 and beginning of 21, availability of the monoclonal antibody compounds has increased, and we have plenty of that available, as do surrounding facilities. So it's important to get tested to find out if you're a candidate for that. We've really seen a big rise in that over the course of the past couple of weeks. We had been to the point where we were administering very little of the monoclonal antibody because we had very few positives. That has increased over the course of the last week or two. So we want people to realize that part of the importance of recognizing those symptoms and getting tested as soon as possible is the efficacy of that is so much better if you get tested early and receive that early on. Any other big things on COVID that we need to discuss this week?
I don't believe so.
Questions?
Yes, there are a couple of questions. One of them you already answered about testing for the Delta variant, but someone also asked about where it's documented that the vaccine prevents the Delta variant. We know it doesn't prevent, but
Right. So when we talk about vaccine, it's decreasing the risk of clinical illness. So and Delta is no different than any other COVID strain in that if you come in contact with the strain, it will enter your body and your immune system will identify it. What the vaccine has done is given you that initial introduction to the COVID strain, and then that way your body responds much quicker to generate the antibodies that fight the vaccine. So it doesn't prevent, it just allows your body to go into action like that, rather than there's a time period of what is this new novel virus and now I'm sick before my body responds. And that, as far as that data, the data that I mentioned, that 88% effectiveness and 97% for hospitalization, that's been CDC and FDA have reported that. And I believe that data is actually coming directly from Pfizer, the manufacturer who's tracking this at a very specific level. Moderna and Johnson & Johnson have not shared actual numbers, but they have said that it is effective in their research and testing against the Delta variant.
another person asked, how do we protect children that are not old enough for the vaccine?
Sure. So just as we have talked about all along, the importance of all of our normal precautions, hand hygiene, knowing who is within your circle, knowing when you're traveling what those precautions are is very important. A lot of people have asked me if they're going to be going on vacation, going on summer trips, planning fall breaks, where is it safe to travel? What circumstances are safe? And very similar to what we said last year, you need to think about who you're going to be around, what the environment you're going to be around is. Not to get onto the cruise industry, but the cruise industry has suffered tremendously because of the enclosed environment, close quarters, so forth, and lots of outdoor activities, including camping, RVing, things like that, have really flourished. And it's because people have been cognizant about that and said, hey, this is what my plans normally would be, but we're going to look at doing this activity, which is more outdoors, more just within our circle of family. And so people should look at that. As Adam mentioned, as we move into the fall and we get into school again, the requirement is that there likely won't be required masking, but the option is still for masking. And as Adam mentioned also, it's important to realize that we don't send sick kids to school and we don't send sick people to work and we don't require people to come in when they're sick. All of these things are very simple precautions, but have become imperative as it pertains to disease transmission. So hand washing, masking when appropriate, social distancing, none of these are new concepts, but it's important to still remember that those are some of our best precautions. And I have patients every day that discuss with me the validity of masking, and I can only go back to one staggering statistic, which was we measure each year how many positive flu cases we have had. And we do that in January, February, March of each year. When we look at all of the influenza cases generally for one season, a year ago, we had almost 1,400 positive cases of influenza. And when we looked at for this past year, when we were doing all the normal precautions as it pertained to COVID, there had been 4. So 1,400 versus 4 is pretty dramatic. And really the only difference was simply all of those typical universal precautions that we have been following. So when those get followed, the illnesses are reduced. You brought up a very interesting statistic that has come up in Missouri and St. Louis area. I want to share that with regards to other viral illnesses.
Yeah, I saw a post from a pharmacist colleague that works at the Children's Hospital in St. Louis, and typically at this time of year, they're very low from a census standpoint, number of children being admitted, and they are actually full and even looking at diverting patients to other hospitals. And immediately before you read the rest of the post, I'm reading it thinking, oh, they're seeing a COVID surge. Well, it was actually RSV and para-influenza, two pretty well-known viruses that circulate communities on an annual basis. And so why are they spiking now? Just some month and a half ago, as masking has really been relaxed, as capacity limits have been relaxed, and allowing back to access to all of the events and being around large crowds of folks has led to a spike in other viruses, not just COVID. So certainly the masking debate is one that will probably be had forever. But when you just get down to the facts of masking, it's pretty undeniable from a scientific standpoint that it prevents the transmission of viruses, COVID and other.
Absolutely. Any other questions for this week?
Yeah, a couple more.
Yep.
Someone just mentioned how they have a 6-year-old that went to the parade recently. Has just been laying around, doesn't feel like he has a temperature, but his eyes hurt. So I don't know what the protocol you might give this person, what they should do.
Yeah, so no different than any other symptoms similar to that. We'd ask that they be seen by a provider. It's very difficult for us to sort those things out without physically examining the patient. By doing that clinical examination, it helps us to rule out common things this time of year. Otitis externa, otitis media, sinus infections, allergies, infections, problems associated with mononucleosis, strep throat, all of those types of things are still out there, just as you listed. So we would encourage them to get in to see their primary care physician, be evaluated clinically. If testing is appropriate, we have that testing immediately available. And then if they don't have a primary care physician, we have our urgent care facilities that are available immediately. If those don't happen to be convenient, or if it's after hours or other times, we have nurse triage lines that the patients can call in and discuss symptoms and get an appointment the next day to be seen. So we have lots of options to get that taken care of quickly. But most importantly, just to get it clinically evaluated.
Do you have that triage line memorized?
I do not, but I can tell you on our website there is our Find a Provider and the triage line are all listed on our website, so you can go out there and take a look from desktop or from your phone. There's a mobile friendly option to be able to find that, and then you can talk to somebody if you're not sure how to navigate. Do I need a provider? Do I go to urgent care? All of those things. There is a line that you can call and you will speak to an individual and they'll help to direct you where you need to go.
Then another question is, have there been any new updates on spreading COVID when asymptomatic?
There have not been a lot of new updates from the standpoint of true data research stating that it's an absolute yes, it is transmitted when asymptomatic, or it's an absolute no. The common belief from medical society continues to be that if asymptomatic, the risk of spreading the virus is much lower. Still potentially possible, but when you talk about spreading of a virus, somebody who has symptoms means that they have that larger viral load, which we talked about a lot in the beginning, as what is a viral load and how does that work. But this virus is spread through our talking, our breathing, and touching of our face with our hands and through those orifices. So when we talk about that, anyone who has clinical illness is going to have a higher viral load, and then when they're talking, more virus is coming out. If they're asymptomatic, that means that viral load has to be lower because their body hasn't got clinically ill. So if there is any risk of transmission, it is much, much lower in that case than in the case of somebody who is ill. There hasn't been anybody that's came out and said that's not possible. Some viruses, it's just said asymptomatic, you can't spread it. But in this case, it is a risk, but it is an extremely low risk versus if you're clinically ill, and you have two individuals not wearing a mask, it's a very high risk.
Okay, I think that's all the COVID questions.
Okay.
All right. And Adam, you'll be back with us again on the 28th, I understand.
Yes, on July 28th, I'll be talking with our new hematology oncologist, Dr. Veta Higgs, and we'll go through her background in coming to Good Samaritan and her practice and what she's looking for in taking care of our community from our oncology standpoint.
And then we have another event coming up August 5th, 5:30 to 6:30. That'll be in the Hetty Center. It's going to be a skin cancer screening introduction for individuals within the community that see patients or clients on a routine basis, massage therapists, hairdressers, barbers, physical therapists, anybody who has physical contact with patients that would potentially be able to identify those things. This got started through a tattoo artist program that was in South America. Is that right? Is that where that initially came from? It's a great idea, though, because all of these individuals who provide services in our community see patients, see their skin, and have opportunities to recognize those problems. And so we're putting on this program primarily as an educational opportunity for those individuals that see clients that will see their skin, be it on their neck, their back, their ankle, wherever they're working on them, to recognize those things. That'll be put in by myself, Dr. Mahan, Allison Wareheim, and then also Dr. Lasher will be speaking with us as well. We will cover not only just melanoma, which is the big bad skin cancer, basal cell skin cancer, squamous cell skin cancer, and then also some normal variants of skin neoplasms. So it will cover all those things. I believe Clint pointed out food will be provided that evening, and that'll be 5:30 to 6:30 on August 5th at the Hetty Center. So thank you all very much for joining us, and Adam will be back with you on the 28th. Thanks.